Hi, I'm Matthew Weinstock, Senior Editor for Hospitals and Health Networks. Thanks for tuning in to H&HN Daily's videocast series. For the past couple of years, Dr. Atul Gawande has been promoting the benefits of the surgical checklist. He says he has seen that relatively simple safety protocol result in dramatic reductions in medical errors in the OR, both domestically and around the globe, through his work with the World Health Organization. I caught up with Dr. Gawande at last week's Health Forum American Hospital Association Leadership Summit to talk about the checklist and his efforts to get it implemented in more hospitals in the U.S. I want to change a little bit and talk about the checklist, which you've famously promoted across the country and across the world. You've been working with the South Carolina Hospital Association to implement that checklist across all the state's hospitals. Tell us what you found in the early goings of that endeavor.
Yeah, this was really just taking a lesson that had been learned in ICUs now about central lines and a basic checklist, being able to work there. And we worked with leaders from Boeing and then of course from around medicine to understand what would be the checklist that could improve results in surgical care. And it was a bundle of about 19 things that we make sure happen, and in the form of a 2-minute checklist. And running through it, we found, testing in eight hospitals, that it lowered complications and deaths by more than 1/3. That initial study had plenty of criticisms, but since then, 2 groups have validated these kinds of results are real. In the Netherlands, taking a checklist approach cut the death rates again 47%. And in the VA system, they were able to take the WHO checklist for surgery that we helped devise and deploy it across 74 hospitals, and compared to controls, they cut their death rates 18%.
And again, though, looking at South Carolina, what have you been doing there, and what are your hopes in that state?
Yeah, so now that we have the evidence that it's beneficial, that doesn't mean places do it. And that's the hardest part, is working to make sure implementation occurs. South Carolina's Hospital Association committed to bringing the checklist into every operating room in the state and making it the routine of care, which is a striking level of commitment. And so we've been working with them both to measure and monitor what are the infections and deaths doing in the state as a whole, but then also being able to structure a process that could walk the hospitals through an 8-week implementation program. We do it through both a couple organizational meetings to get it off the ground, and then an online WebEx that we now have had 45 of the 67 hospitals walk their way through this process with us, with a kind of weekly check-in, almost like homework that we do with them each week. We troubleshoot and help solve problems, and then after a cycle of 8 weeks, they've been able to walk through their process of getting it piloted and into place in a starting set of operating rooms, and then work to deploy all the way through their system from there.
And the next steps for then the checklist, you're working with the federal government to potentially get a grant to do this beyond South Carolina, right?
Yeah, we'll hear in the next few weeks that with AHA's research and education arm, we together put a grant to them to be able to take the checklist work we've been doing to 5 states. So take it from 1 state to 5 states, make sure we can replicate it at that level for a year, and then to all states, so that we're able to not just say that we are doing the checklist and its parts of care, but actually make it effectively real, that it really has become the norm.
For a hospital executive that's looking at the checklist and deciding whether or not to try to implement this through their system, what's the biggest challenge in doing it? Is it a cultural shift with the clinicians? Is it building that team, that framework of teamwork? What's the biggest hurdle?
I think the culture shift is without question. Embedded in the checklist is a set of values. It reflects humility to use a checklist, you must be humble enough to think that you might fail. You have to have a willingness to believe in discipline of following a checklist, and then teamwork, a belief. The checklist is fundamentally about having everybody communicate with one another, about the plan, is blood ready, all of those kinds of things. And that teamwork aspect is also not something that we necessarily really embrace. Being able to make that set of values central to what a surgical system does, whether you're doing 3,000 operations a year or 30,000 operations a year, is really hard. It means setting certain kinds of goals, being able to create a team that includes a surgeon, an anesthesiologist, a nurse, leader with a leader that represents the CEO, and then clearing the way for all the hurdles that come so that people are taught how to do it, and then there's a return to checking and improving and seeing how it goes. The value of it is that when places have adopted it, they see the results, but they also experience just the better morale of teams that work together. We've seen declines in mandatory nursing overtime because people have communicated the plans from the beginning of the day and been able to make arrangements ahead of time. And we've seen some places that, like the Kaiser system, that have found improved nurse retention. So that sense of teamwork is incredibly valuable to create. We have some steps that we've been learning about how to get there and walk your way through step by step. But there's no question, without that leadership that embraces those goals and values, it doesn't happen.
Thanks for watching. And for more coverage of the American Hospital Association Health Forum Leadership Summit, be sure to go to our website, HHNmag.com/2011 Leadership Summit. You'll be able to find the first part of my interview with Dr. Gawande there, as well as other blogs and videocasts. Thanks.